I'm doing hand and finger stiffness. So we'll keep going. Why does stiffness occur? I think that we've just heard from some great speakers that it can occur just naturally, but some things that we can think about as hand care providers is prolonged immobilization. If you just keep that splint on for 2 months instead of 2 days, multiple traumatic injuries. Certainly there's patient characteristics that vary from region to region, city to city, a delay in appropriate care that may be controllable, may not be controllable, and the dreaded insurance limitations. So prolonged immobilization can certainly happen in cases where there's no surgical indication. There's just no tissues that can be repaired. We just don't have the capabilities yet. What drives us a little bit crazy, and I'm sure you guys have all experienced this, is cast length or splint length, really. So sometimes our emergency room peers do the best they can, but they'll take someone who's 80, a non-displaced, nothing, just a radius fracture, and put them in a splint past their elbow and past their fingers when they really could have just been fine with an ACE bandage and or maybe nothing, and generate finger stiffness and generate elbow stiffness. And then my other personal favorite is the dreaded sling, and they'll put them in a sling, and then you have shoulder stiffness. So these are all things I think that my greatest success is just to take the splint off that person and give them their life back, and they're so much happier. Certainly this injury is probably going to generate more stiffness and problems than some other injuries that would have less. There's certainly going to be an element of non-compliance. Patients tolerate things poorly. What their occupation is. Certainly there's patients that are more motivated to return to function than others. There's certainly a fear component, a motivation component, and a pain component. Insurance does play a part. I mean, it's interesting. I have some friends that are way wealthier than I am, and probably wealthier beyond wealth, and they refuse to spend money on their healthcare, but they will. For instance, a friend of mine dropped $100 tipping the valet, but refused to go get a $300 MRI scan to try to improve his healthcare. So the people are very fixated on their insurance costs, and the copays keep going up. My practice rates keep going down, yet we pay more for our employees. Certainly, the services aren't authorized. Splinting DME becomes more and more challenging, as I just learned that each one of our 17 offices now has to have a separate CMS authorization to do splints, just adding to the paperwork. So we've realized all those things. So now some concepts on how to avoid stiffness, controlling edema, getting the fingers motion, I think is most pertinent, right? I try to teach patients that the intrinsic muscles in the hand work like small hydraulic presses and start to move fluid out of the hand. And it's sort of a catch-22. If they don't move their hand gets more swollen. The swelling leads to more stiffness and kind of that round and round cycle that we're trying to break. Sometimes it's just education more than anything else. I think then just the right challenge, you know, the no pain, no gain concept really doesn't work well. And for the therapists, I saw there's tons of therapists here, so thank you for helping solve all my patient problems, since I'm doing a terrible job and then the therapist saved me. But from the pushback is, you know, some of the patients will no longer use the word therapist, then they'll use the word terrorist. So we want to try to, you know, use intense therapy, but not aggressive therapy. And, you know, there's that fine line. And then, as we just heard from Dr. Stone, trying to do an evaluation is super helpful. The therapists in my practice spend a ton more time learning about the patient, talking to the patient than I do. So we're trying to figure out, is it really a joint problem itself, or is it a soft tissue problem like a tendon problem? And you can compare active motion to passive motion. If they have good passive motion and poor active motion, it's probably a tendon adhesion problem. And if both motions are poor, then it may just be an arthritic joint or a bony block or something like that. I think it's important to keep in mind the joints that are most challenging is to get the wrist into extension, get the MP joints flexed, and the IP extended. So people that have a PIP flexor contracture, pretty dreaded. Joint stiffness comes about from ligament shortening, joint capsule tightness. Again, there could be a bony block. Intrinsic tightness testing. There's a million different articles on all this stuff, and it's hard to keep in mind. So I thought I would just throw this slide up there. And if the MPs are extended, then your extrinsic tendons are slack, right? It's really easy. So if your MP is extended, the extrinsics are on slack, and if they can't flex their IP joints, it has to be an intrinsic problem because the extrinsics are slack, and vice versa. So if your MPs are flexed and then now your extrinsics are tight, and if they can bend their IP joints, then it's not an extensor problem, it would be an intrinsic problem. So you don't really have to remember any of these slides. You just have to know if your extrinsics are tight or slack. And again, if they can't move in either direction, then it's a joint contracture in and of itself. Again, this is another little thing looking at the SORL, or spiroretinacular oblique ligament. And you can see decreased passive DIP flexion. Again, a very challenging problem to treat, but it is important to make the diagnosis, and then we can kind of work together on figuring out what to do. Generalized scar, you can see that blanching or whiteness as the patient tries to make a fist. Where it is white, it's certainly tight, sort of the concept. The corollary in the operating room, where it's white, it's going to be black if you don't get that blood supply back. Nerve function is certainly something that can be missed. If the patient's just swollen and stiff, we may not necessarily realize there's a nerve generating problem until they do get some of their motion back. So how to manage edema. We all sort of familiar with Coban, isotoner gloves, the tubing grip, elevation, active motion. Again, I like the active motion best. What happens oftentimes when they take that isotoner glove off, a lot of times the fluid just rebounds, and unless they're getting their fingers motion, a lot of patients think that isotoner glove is like the next coming of sliced bread, and they put that glove on and they're going to have the magic. It's a magic glove, I'm sure, but in my practice, it's not that magical. So I think these are sort of really very helpful. These relative motion orthosis. And again, you can see here one that's sort of blocking the patient from moving their MP joint. So patients learn to cheat really fast. So it's easier to bend your MP joint than to try to work on the PIP joint, which is going to generate some soreness and stiffness. So if you actually prevent them from cheating using this relative motion orthosis, so they're going to have to focus on obviously the PIP joint. And the flip side is if you're trying to get PIP extension, you can block their MP from extending, again, preventing them from having that cheat move. I thought this work from our group and Jane Fedorczyk is, in reality, patients don't necessarily need to make a full fist. It's nice, it's lovely, they're looking at their hands all day. People don't see their feet. So if they have foot stiffness, toe stiffness, they're not seeing it, but your hand is in front of you all day long. But patients are pretty functional with 60 degrees of MP motion, 60 degrees of PIP motion, and 40 degrees of DIP motion. And anyone who's ever treated someone who's got rheumatoid arthritis or an elderly person with diffuse osteoarthritis, they're pretty functional despite not necessarily having a perfect hand. Again, we're all familiar that the thumb does quite well with limited amount of motion. The digit widget is certainly out there from a surgeon's perspective. You can attach this and use various techniques to try to move the finger into extension about the PIP joint, move it into flexion. Of course, this slide shows the border digit, right? So it's not as easy to do on the middle finger or the ring finger, but it is out there, particularly for the small finger. And in closing, I just want everyone to sort of think about or discuss, what would we do to sort of maximize this multi-trauma patient, right? You can see there's pins, there's a soft tissue envelope, there's swelling. And this gets into great discussion, I think, or I was hoping, because there's fractures. K-wires maybe aren't the most biomechanically stable fixation. So do you start this patient moving early? Anyone have any thoughts? Jason, would you get this patient moving straight away? Just
Yeah, I think after the 3 to 5 day window, like was mentioned earlier, I think that's important. Let the swelling settle down, and then allow people to move early to minimize the adhesion.
Yeah, I mean, I think, right, so there's this concern that the fractures are going to displace. And my teaching to the fellows and the residents is it's our job to get the fractures to be pretty stable, particularly if we take the patient to the operating room. And I have less concern that the fracture is going to shift down the road because fractures can be remanaged, they can be revised a lot easier than the soft tissue envelope that we've sort of heard about in the last two talks. So I think it's important to strive to get the joints moving, get rid of all this swelling, and we can worry about surgically managing the fractures down the road if they do further displace. I think being too tentative is probably erring on the wrong direction. So, any other thoughts about this?
Internal fixation and lock further further distal and proximal phalanx, medial phalanx, PFE joint, placing the ball feet and small fingers, and really create a lot of adhesions. So, in the hand, I think for sure your goal should be at the initial treatment to try to rigid to 65 block over motion. As you get into bigger trauma, I think that I'd rather have a stiffer straight finger that I can deal with later than a perfect finger that is hard to knock beyond.
Yeah.
So in the hand, I think for the finger, I think
that's a good point.
Definitely work to make metacarpal as stable as possible, really not possible to keep it in the hand. I have less success around the partial and field joint than I do around the wrist metacarpal.
It was really geared towards the P1 fracture or proximal phalanx fracture that, and we've done some studies in Philadelphia looking at K-wire fixation versus plate and screw fixation with Mike Bednar's partner, brother John. And the results were equally poor. And the debate will continue to rage on those two concepts. And maybe there's going to be a newer technique. Maybe the IM nail fixation will be a better way to go. But
I'll have flavors outcome to the other fell down and had a score actually fracture.
Yeah.
Then I want the guy's hand and not press.
I agree. I don't know what to do.
And I remember residency as Mike Bednar gave me a talk about there's awesome pictures I've never been able to find again. That was a cross section of a finger, and it was basically skin, flexion tendon, bone, stiffness tendon, skin. That's it. And you add even a millimeter of metal in there, you're really screwing with the entire relationship of every structure in that digit. And so bigger fracture sucks. I thought about cancer with 8 fingers. But I agree with you.
Yeah, the pins are going to go through the extensor, and people talk about going lateral to the tendon insertion, but you're going through the extensor hood one way or the other with K-wires, right? So
completely free, fighting completely free, you have the patient extend their finger and you still can't do it. It's like finger mucking around in the lumbar now. And it gets markedly more complex, especially doing these things more like it actually how and interact. Theoretically,
I wanted to have more discussion.
but the reality is even though
All right, and my last slide here. Please pray for us, please. That's all I can say.